So I'm going to speak a little bit about the pathophysiology of facial dystonias. This is a difficult topic in some respects. There are many people who have come before me that have made propositions of what parts of the brain are most affected, what parts are least affected. And it seems that with every research project done, with every publication made, and with every patient seen, we think there might be something different going on. And so in some respects, that can be frustrating. In others, I think it really speaks to the complexity and interest which many of us have in trying to help patients and families like your own. And so hopefully we'll continue to push the envelope to be able to help discover those things. I have no relevant financial or non-financial relationships to disclose related to this talk. So I think we'll also see today there will be some moments of crossover in some of the talks. And that's because it is such a broad topic, and I think it helps that we continue to emphasize what we do know about blepharospasm and the facial dystonias. So when we're thinking of any dystonia, as Dr. Lee had mentioned, we're talking about excessive, patterned, involuntary muscle contractions. This separates it a bit from some of the other movement disorders that we see. When a patient comes into our clinic and we're trying to help characterize what their movements are, it's very important that we break them down into categories where we look at things like the pattern of activity, or whether it looks like it's an excessive involuntary or even voluntary movement, or a lessened voluntary or involuntary movement. So with dystonia, it's excessive, it's patterned, it's involuntary, and this results in postures, sometimes cramps without posture, so patients can feel their dystonia even prior to when they see it. And oftentimes it can be repetitive, so it'll take on an appearance of tremor or tremulousness. Now in blepharospasm, we think of it in a couple of different categories that I like to separate into tonic and clonic, and many of you will experience both at any given moment. The clonic refers to the repetitive movement, so excessive blinking, excessive speed of blinking, rather than the usual blink rate over a certain period of time. There's more blinks going on. But also there's a tonic involvement, meaning that the eyes can squeeze, they can maintain that posture and maintain that contraction. We do recognize that with most dystonias, they are worse with stress, with fatigue. Some medications can actually worsen them. Dr. Lee had mentioned the types of dystonia that come as a medication side effect, but even some medicines that might be in your ordinary armamentarium that are given to you by another physician may worsen your dystonia at any given moment. And we recognize that it's better with rest and sleep. We also recognize the many sensory tricks around the room. This is where we know that there are sensory inputs to both the cortex and the basal ganglia and the brainstem that seem to modulate the movements. This also goes by the French term, the geste antagoniste, the idea that you could do something as simple as this, which I see a couple of folks doing. Let's see if we've got some other ones that I can see. I see one that's going like this, something like this. Now, as I teach my residents, a sensory trick is not this. This is effective. It'll hold the eyes open, but it's not truly the sensory trick, which is much more subtle, which relies upon some sensation of both position and feel that the brain experiences to try to modulate the dystonia. And then finally, we'll talk a little bit about meds and surgery with some other groups. There's also various organizational schema that have been proposed. Even some changes to this have happened within the last year. As a rule, we think of that as age of onset, young versus old. We think of that as either primary or secondary or idiopathic or symptomatic or essential, meaning that there might be a clear cause, an antecedent event, maybe from a stroke or from another neurologic disorder, or it just happens. And we also think of it organized within the body. So with something like blepharospasm, this would be considered fairly focal. There are task-specific dystonias like writer's cramp. Hopefully none of you will get that today. We'll have the slides available to everyone, so don't feel like you have to do too much writing. There's also other focal dystonias like cervical dystonia with pulling, or even limb dystonias of the feet. But you can also have segmental, meaning two adjacent body parts that seem to be affected, like the eye closure of blepharospasm, plus the oromandibular features. That's classically called a M.P.H syndrome or a Bruegel syndrome. And then you can have hemidystonia, half of the body affected, more likely seen in structural abnormalities, tumors, strokes, birth injuries. And you can have generalized dystonia, which as a rule has a genetic cause, affects children more frequently, and we recognize that it is uniquely beneficial to surgery. For this crew, we're talking blepharospasm. We're talking sustained, forced, that would be our tonic, repetitive, that would be our clonic, involuntary closure of the eyelids. But we aren't the first to recognize this. So going back to the ancient Romans and Greeks and parts of Macedonia, does anyone recognize who that bust is on the left? So that's Alexander the Great. There is some speculation that he and others in this era may have had some degree of cervical dystonia. And there are other busts that were made that actually showed some narrowing of the palpebral fissures of the eyes as though they had blepharospasm. Now, many of the busts that exist from this era are in these postures. So if you've walked through the Uffizi Museum, for instance, you'll see many busts like this. So there's a question of whether or not this was also, and for many people, just recognized as a pose, recognized as a sign of beauty, perhaps. And that's why there were many of these busts made. But it could also be some of the earliest signs that we had of at least recognition of focal dystonias. Publication was made several years ago that showed this bust here. This is thought to be an ancient representation of M.P.H syndrome in pre-Columbian Peru. The terminology of pre-Columbian Peru refers to prior to Christopher Columbus being there, and probably sometime around even as early as 100 to 500 AD. So you can see, again, some narrowing of the eyelids. You can see a face of smiling, maybe grimacing. Hard to know here. We also know that in the Veracruz culture, there are several busts that have been made showing clearly narrowing of the eyes with grimacing of the face. And even the sensory trick shown in this bust in the lower right corner, where there's a sensation of the bust putting their hands on the eyes and demonstrating that there is some improvement, perhaps, from what would be seen on the left. These two on the lower side here, both this one and this one, are actually here in town in the New Orleans Museum of Art. So some of you may recognize this one. This is sort of felt to be the classic rendering by the Flemish painter Bruegel of the yawning peasant, or the yawning patient, perhaps, demonstrating blepharospasm with eye closure, but also a jaw opening dystonia as part of the oromandibular. And so in some groups, people will refer to the eye closure with jaw opening as Bruegel syndrome, and eye closure with jaw closing as M.P.H syndrome, as Dr. Lee had mentioned. And perhaps in contemporary art, these are paintings that have been made within the last 50 years, we continue to see models and subjects that are shown with what looks to be here a cervical dystonia with the sensory trick trying to help this young lady. So what leads to blepharospasm? And frankly, what leads to all dystonias? And Dr. Lee hit on this. It's a multi-hit hypothesis. We recognize that there are genes. Some of these genes are what we call Mendelian, meaning that if you inherit these genes, your risk of developing a syndrome is quite high, sometimes 100% with some disorders. Others can be variable. So in the dystonia world, the DYT1 gene, which has been linked to a type of dystonia we call Oppenheim's dystonia, oftentimes will present with the generalized dystonia in children. But we're reminded that perhaps the father who passed that gene only has writer's cramp. And so you may see a different phenotype or presentation in your clinic of a single gene. The DYT6 gene, which is also one of the genes that is now commercially available to test, associated with a protein called the FAP1 protein, actually presents oftentimes with quite a bit of facial dystonia, blepharospasm, oromandibular movements, before it also seems to progress into sometimes a more generalized presentation. And then there's also protective factors and risk factors. There's a whole host of these that have been proposed. Some of the protective factors for dystonia may mimic some of the protective factors that we see in other movement disorders like Parkinson's disease. For instance, caffeine intake may be associated with a decreased risk of developing dystonia over the years. And there may be other environmental exposures, such as pesticides and insecticides, that may increase the risk of developing a dystonia. And so while it's a little bit of a clunky analogy, some people have said that your genetic makeup is essentially what loads the gun. And what happens later, your environmental exposures, the protective effects, the risk factors, That's sort of what pulls the trigger for a lot of diseases, and dystonia falls in that same category. So when you're thinking about dystonia of the eyelids, like we largely see in blepharospasm, I think it's helpful to go over what is affected externally. And not truly externally, right? I mean, you have skin covering this. But when I think of externally, I think of what's going to be experienced by the patient, what's going to be seen by their physician and their friends and family members. And so this goes over the primary muscle that's involved. It's the orbicularis oculi. It's a circular muscle that goes around the eye. There are other ligaments that are involved, like the medial palpebral ligament. And we do recognize that the lateral palpebral ligament has an involvement, too, on the edge. These are the sites, these muscles plus others, demonstrated here, that are targets of things like botulinum toxin therapy. So we recognize that on the left side, there's the musculature involved. But also, we talked a little bit about photophobia, or the light sensitivity. But there's other external sensory inputs, and that might be modulated by the lacrimal gland. So the fact that you can have excessive tearing, either as a reaction to blepharospasm or perhaps as a trigger. So then what's affected internally? Well, this is where it gets weird. So this is one of many proposed pathways, series of pathways, for which the internal structure, the central modulators for dystonia are involved. And I leave this up here only briefly to remind myself and others that there's still lots to be learned, and in fact, lots of opportunities for modulation along those pathways. But before we panic, we're going to make it a little more simple. But then I was reviewing this one, which is from a recent publication too, and I like this one actually. It does describe that parts of the brain will have a motor output. So you, again, as Dr. Lee mentioned, you imagine reaching for that cup of coffee. Or when it comes to blepharospasm, you have the ordinary blink reflex that starts involuntarily. But then there's many sensory inputs of position of the eye and other sensations that you experience that then creates this feedback loop. But I thought that was a little bit clunky too. So here's mine. So why do your eyes blink too much? Well, when we blink, you're either going to make the blinks go or you're going to make the blinks stop. And this is a balance. So for someone without blepharospasm, the central modulators are in balance so that the peripheral, what we call the blink reflex, can do what it does. The blink reflex almost has a timer related to it. So you know that it's ordinary to blink somewhere between 8 and 15 times per minute. So that timer goes, and we'll talk a little bit about the blink reflex in a minute. But essentially, if you're going to go with your blinking, you will have central facilitation, so one gate is open, trying to make movements happen. Again, it's true for many of the movements that we make, both voluntary and seemingly involuntary. So there's central facilitation on the left. But there's also central inhibition. It's another gate in the basal ganglia that is designed to prevent unwanted movements. So now on one hand, we're getting facilitation and assistance of wanted movements, and in the other hand, we're getting blockage and impedance and inhibition of unwanted movements. It's true for blepharospasm, it's true for all the dystonias. Then other things that will allow it to go is, again, this feedback loop of sensory integration. Part of that is what we call proprioception. So my brain realizes the position that my hand is in as it reaches for something, or as it's walking along, or as I'm sitting talking to somebody and trying to prevent having a dystonic outburst from my neck. We realize that the body is sending information, and the brain is making adjustments so that there's sensory integration always involved with the movements. And then finally, there's an effort to maintain the appropriate latency. So that's a little bit of a governor on reflex of the eye blink. So you're not always blinking like this. There's a latency involved that after you've had one blink, there's a time period that goes on before you make your next blink, involuntarily. So here's what happens when your eyes blink too much. The central facilitation is unleashed. The sensory integration is abnormal, it's deranged. It may give the brain the sensation, though you don't have this sensation, of something in your eye or a light sensitivity that keeps the cycle going. Similarly, the things that we would imagine would stop blinking, like our inhibitors, like that second gate, right? We want one gate open. We want the other gate stopped. We want the facilitated movements open. And we want the blocking movements stopped. That one opens. So you have less central inhibition. So now you can have what we call co-contraction of muscles. You've got two muscles that are going at the same time, and they shouldn't be. And the latency, and this is unique to blepharospasm, the latency is shortened. So there have been very elegant EMG and other detailed studies that have been done that have shown that when you stimulate and force the blink reflex, that the second blink, the third blink, will happen more quickly and will not have the ordinary latency or prevention from going forward. So let's think about the blink, right? You get decreased inhibition, one gate's open, which then leads to even more facilitation. And in the brain, we think this happens all over. Somebody who's done much of the work with this, along with Dr. Stacy, is Dr. Mark Hallett at the NIH. He spoke to this group 2 years ago, maybe? And I can remember actually watching that video from YouTube or somewhere when it was brought up. And it was reassuring and humbling in many respects. Somebody like Dr. Hallett, who really has made a career of looking at motor control, he stood up there and said, with every month, with every new paper that comes out, even he is more confused about whether it's basal ganglionic, whether it's cortical, what part of the cortex, the thinking part, the purposeful part of the brain is affected, where this brainstem meets, because that's where the blink reflex then crosses through, and the cerebellum, our balance part of the brain, part of the brain that is fairly underrepresented in humans compared to other animals, might be what's affected in dystonia. But we do know that there is this central problem of decreased inhibition and more facilitation. And we think there's some sort of inappropriate sensory integration then. So there's some problem with that central process, recognizing that there is an irritant. Again, I don't mean a physical irritant like a sensation in your eye, although many patients experience that. But there's some irritant to that sensory system, to that feedback loop, so that it tells the brain to make that wrong move. And then it provides wrong feedback about that move. We talked about the decreased latency. So in normalcy, that next blink is suppressed. But in blepharospasm, that next blink is allowed. It goes, and it goes, and it goes, and it goes. And finally, there's this theory of something called cortical plasticity. So we realize that the brain over time is plastic. Now in medicine, outside of medicine, in the real world, when we think plastic, we think durable. We think firm and unchanging, right? There's nothing more plastic than the Matchbox cars and other things that my kids play with, and they're indestructible and they don't move. But in the brain, when we think plasticity, we actually think of it differently. We think of it as something that is modulable, and that over time, there are parts of the brain and parts of the brainstem and parts of the basal ganglia that actually will increase their plasticity. And in some respects, that's a good feature. That means after somebody has had a stroke and they're left with a certain part of the brain that's damaged, the surrounding parts of the brain sort of call in the troops, and they can be plastic. They can change a little bit about what they do, and they can take over for things that have been left to the wayside due to the stroke. Plasticity isn't always good, though. And we think of it in blepharospasm as perhaps contributing to some of the abnormality, where the brain then sort of goes out of bounds and increases what it does from normalcy to abnormalcy. So this combination now of the decreased inhibition, the inappropriate sensory integration, we know that there is a decreased latency of the blink reflex. Then finally, over time, the development of cortical plasticity that is not to the blepharospastic patient's advantage probably is what wraps this all together. So then, loss of inhibition leads to that sensory confusion and poor feedback looping, leads to shorter blink latency. And then finally, you do get greater force and a greater rate of blinking. So then we can come back to this and say, well, then the cycle goes from the motor outflow, right? So you have a thought coming out of here, an intention to blink or to grab something, and it starts to flow out to the body, to the peripheral part of the system, what you see on the outside. But in the nature of milliseconds. It's making adjustments. And hopefully, with some of the medications that we're developing, with some of the surgical opportunities with deep brain stimulation of the globus pallidus and others within the basal ganglia, we can then close that extra gate that's allowing involuntary movements to proceed and really keep in check some of that sensory outflow. So before I close, I was going to just give a little bit of an exception of the hemifacial spasm, because I know we're going to talk a little bit about the use of botulinum toxin therapies and other potential treatments for other facial movements. And this is the one that's different. This is the one that's special, and Dr. Lee hinted at it a little bit. So as I talked about the complication or the complicating nature of blepharospasm having central control and then the peripheral outflow of that, hemifacial spasm is peripheral. It is a pure irritative problem of that facial nerve. So this is really what we would consider a peripheral nerve movement disorder. At different times it's been called a peripheral dystonia, peripheral myoclonus. But the reality is we can just call it irritation, because what we're having here is irritation of the facial nerve where it comes out of the brainstem. And as Dr. Lee showed in her video, you will see, again, both tonic and clonic movements of that one half of the face, because it is only that part of the facial nerve that's irritated. It can be idiopathic. It's a fancy word for what we do that implies that we don't know the cause, and it's probably not ironic that it almost has the root word of idiot in there, idiopathic. So we're not really sure what's causing it. You can have a looped blood vessel, and that's what's shown in the picture here at the bottom, highlighted in yellow, where oftentimes an aberrant or extra blood vessel or an enlarged, engorged blood vessel, or even an aneurysm, something where there's been weakened of the edges, just strays a little bit off path. And having that bump up against the nerve encourages that nerve to send some extra signals. And then those signals, once they go, they go. And the third reason that we tend to see it is after a facial palsy. So somebody who gets a Bell's palsy, or even has had a stroke of that area of the brainstem, over time, if that nerve is blocked up here, it grows back. And it tries to find its way the right way. But sometimes those nerves get crossed, and they cause what we call, they develop what we call facial synkinesis. Fancy word that if you close your eye, your mouth pulls up, or if you draw your mouth down, your eye will close. Because in fact, the nerves are confused on where they're supposed to be acting. And then you can even see other odd stuff. So if you were eating that delicious meal down in the French Quarter after you've had a facial palsy for several years, when the stimulation of the tongue and the taste mechanisms happen, you'll actually sweat. So you can develop what we call gustatory sweating. You can have other episodes where it's called the crocodile tear phenomenon, with the way the tears will flow. But along with that facial palsy, sometimes the nerve itself is more irritable. There's some more crisscrossing of the fibers. And so after a facial palsy, it's probably one of the types that we see in our clinic happening the most, months to years later, where then things like botulinum toxin therapy can calm down the movements. But remember, if it's weak underneath, sometimes you then will unmask the weakness that was there before. And with that, I appreciate your time, and I'm happy to take a couple of questions.